From KMOB 1003 Global Media, this is
President and CEO of KMOB 1003. February is Heart Health Month, but in Black communities, heart health is not seasonal. It's shaped every day by access, prevention, and lived experiences. When we talk about heart disease in Black communities, we often talk in numbers, but behind every number is a person, a family, a future altered all too soon. This series asks a simple but urgent question. Why are Black hearts failing sooner? And what can still be done before it's too late? That's the conversation we're here to have. I'm joined today by Dr. Anthony Fletcher and Dr. Sandra Bruce. I'll ask each of you to introduce yourselves in your own words. And Dr. Fletcher, thank you, and I'll start with you.
Hello, and thank you very much for this opportunity. I'm Dr. Anthony M. Fletcher. I'm an interventional cardiologist based out of Little Rock, Arkansas, CHI St. Vincent. I've been in practice for over 40 years in terms of experiencing the ravages of cardiovascular disease. I'm also the 20th president of the Association of Black Cardiologists, and we look forward to this opportunity to share with you today.
Thank you so much. And Dr. Nichols?
I am Dr. Sandra Bruce Nichols. I am a walking miracle. I'm a mother, I'm a wife, I'm a physician, I'm former commissioner of health, former chief medical officer and senior vice president at United Health Group. And today I'm so excited to be here because I am a transplant survivor. And as a transplant survivor, it's so important for you to hear about what happens when a physician meets death through not caring for herself.
Thank you both. So exciting. So we're going to talk about the reality today here in our episode 1. And Dr. Fletcher, we hear so many people talk about when you say Black hearts are failing sooner, what does that mean in clinical terms? What are you seeing earlier than you should as a cardiologist?
Ms. Nichols, certainly thank you for that observation. Black hearts fail early because so often, unfortunately, we have afflictions with cardiovascular disease at an earlier age. And also, very often, we die at a younger age because of those afflictions. And so in many cases, our risk factors for cardiovascular disease occur earlier. They're unrecognized, they're undertreated, and sometimes we just don't have access that we need to be able to address those issues. So because of that, many times Black lives are affected earlier and unfortunately die sooner with these complications from cardiovascular disease.
Wow. Thank you for that. Dr. Nichols, you have lived experience. So, and you're part of policy making and you have this book. It's just so much we want to start off asking, what were your indicators? Did you have any indicators? They talk a lot about that Black women, we start off, we have more stress, we have family, we just have a lot on us and we just keep going and going. Did you get any indicators?
Absolutely. The warning signs were there. Fatigue, shortness of breath, chest pain, difficulties to sleep, interruptions of my sleep. But all of them were normalized by me because I had to be the best. I called it aging. I called it just pushing through. In Black communities, especially, symptoms are often minimized, but especially with Black women, by the patients. All patients that are Black individuals seem to ignore those symptoms. And what's so amazing to me is that once we identify those symptoms, sometimes they're minimized by systems, by family, by physician, and especially by the individual who at last would say to themselves, I can keep going, but the body states, I cannot compensate anymore.
Dr. Fletcher, I'm going to ask you to weigh in on that because you see what the common first domino you see, blood pressure, diabetes, stress, delayed care. And it starts a cascade. So based on what Dr. Nichols just said, will you weigh in on that?
Dr. Nichols' description of her symptoms are very common and obviously easy to confuse. She's a very busy professional individual, a mother, a wife, and just going about the day-to-day business of pursuing excellence in all 3 domains. And so to be fatigued and not sleeping and tired those can be very common symptoms that may not necessarily be associated with cardiovascular disease. It could be just from, you're doing 30 hours in a 24-hour day. So I think the importance of it, though, is as we talk today, to be sure that people understand that there are normal aspects of day-to-day living. But I think the important part is to be sure that you are doing the appropriate health observations or screenings, that you're checking your blood pressures, that you know your numbers, your cholesterol, your sugar, your weight, your just overall day-to-day kind of numbers that we need to know, and that you get your physicals so that you can check in, just as we take our car in for an occasional checkup or tune-up. We need to do that with our bodies so that we can see whether or not the wear and tear of our professional careers is having a significant impact. And the only other part that I'd like to make too on this point is know your risk even before we start these professions. Know your family history, for example. Does hypertension, for example, run in your family? Does heart disease run in your family? And then if you know your numbers, what are your risk factors for the potential for you becoming a victim of cardiovascular disease?
Thank you. You know what, Dr. Nichols, I didn't get the opportunity to ask you this question, but because you are a heart transplant physician, when you hear the words running out of time, what does that mean to you?
Gosh, that is a fantastic question. I learned so much through this process. And when I think about running out of time, it never crossed my mind. It never crossed my mind because, as we all know, as women, are told to keep going, to keep going. You have to be the one who does it all. You're, as we talked about earlier, the mother, the wife. In my case, I was a physician. I handled patients. I handled my employees. I did it all. I became a physician to protect. That's what I told myself. I became a leader to change systems. I became a survivor from a massive heart attack and ultimately a heart transplant to testify that I have lived long enough to know that excellence without humanity is an empty vessel. You must focus on yourself. You must understand what are your limits. That education without compassion is incomplete. That success without purpose is hollow. So it was great to have the success of all the things I was doing. But what really came to bear was that faith is not optional. And when I sat in that CCU day after day and came in and out of that operating room, I knew that God had a purpose for my life. He and that only He, although Dr. Fletcher, I wouldn't be here today with people like Dr. Fletcher who guided me through some of the things as I dealt with those issues. But a purpose for my life. I would not be here unless God had saw fit to fulfill that purpose for my life. So when I think about that question, I can't help to say that, it is so important to know that we all are running out of life. There's no date or no time that's given to any of us. What's most important is that you balance your life, that you appreciate the life that God has given you, and you put yourself first.
Thank you. That was a valuable input. Dr. Fletcher, I think a lot of young people, even, people in their 40s, they believe that heart disease and heart attack is an older person disease, that they don't have to worry about that. Also, you mentioned earlier about getting that care that you need, but a lot of people don't have that medical insurance. I mean, what do you do in those situations? So is it starting younger? What do they do if they don't have health insurance?
Well, first of all, I'd like to say amen to Dr. Nichols' testimony here just a moment ago. Certainly, I think that one of the things we have to understand when we talk about running out of time, when we take that first breath when we're born, the clock starts ticking right then. And nobody knows how long that clock is going to go. You might be destined to live to be 100 years old. You might be destined to live to be 20 or younger. But I think the most important thing that we should all recognize and realize is that each and every day is a special day. It's a precious day. And as a result of that, we want to kind of reflect about, how can we live our lives to its fullest potential? I tell people all the time, when you're going to die is in God's book. He's got that. He knows what day we're all going to leave here. But
Yes.
the difference that we can make is the quality of life from when we start our process of aging until we get to that final day. So if we take care of ourselves with preventive care, The latter parts of your life may be active, being with friends and family and continuing to do the things in life that you enjoy, as opposed to being disabled and unable to participate to the full degree of life that we'd like to. When we talk about the whole process of early screening and prevention, I think that's the key. That's where we have to start to work. Unfortunately, in today's times, we spend so much energy and finances on the terminal phases of life, trying to rehab and rehabilitate and kind of slow disease processes. Our key opportunity for intervention is the preventive aspect. And so that's where we get into the concerns about lack of insurance and lack of access. Because as we start in our, childhood years and our preteen years and our teen years, that's when we need to do our screening. That's when we need to do our education and our preventive practices, eating correctly, maintaining ideal body weight, exercising, being knowledgeable about the signs and symptoms of diseases, and knowledgeable about our family history in terms of the potential risk that we may face from a health perspective so that we can modify those risks as early as possible.
Thank you so much for that. In the Black community, we have a mistrust for physicians, and sometimes that's passed on through history. And it doesn't have to be passed on through history. If you're following social media, you see it every day why, a young Black male goes into the hospital, the way that they treat that young Black male. A woman goes into OB/GYN giving birth and how they're treating her. And so with the mistrust, and this is for both of you, what do we do if you're hurting and you're in pain and you feel like they're not going to give me any attention? They're going to tell me it's all in my head. So what do we do?
Pam, when I think about that, I think we are saying to ourselves that our life is collateral damage. The issue is what you think might happen if you go to a hospital or to emergency room. So your life is not collateral damage. Your health is not optional. Your rest is not selfish, right? You are here because you were allowed to be brought here by a God, in my humble opinion. And that purpose supersedes everything else. And so all of us must honor our body, our mind, and our spirit by listening when it whispers. Because if we don't listen when it whispers, I am a living witness that you never want to hear it scream.
Thank you. Dr. Fletcher, you want to weigh in on that?
Absolutely. I think the very important part of the whole process is education. I mean, first of all, we have to understand the nature of the illnesses that we potentially face. Number two, in that educational process, we need to realize that ignoring those disease entities or the potential for the risk factors that can accumulate in your life, you put yourself in harm's way for all the things that you have the most as far as complications. The other part about this is that as the part of the educational process, we have to learn to advocate for ourselves. For example, when you go to see a provider, you should know the numbers that they are collecting from you, your blood pressure, your heart rate, your weight, your cholesterol, your sugar. All of those things are important that you know those numbers so you can advocate. Pay attention to what tests we should ask to have performed on ourselves. Simple things in terms of just being able to say, well, doctor, what is my cholesterol? Well, what are my risks? Why should my cholesterol be higher or lower? What tests can I do to help me discern whether or not I'm at risk for cardiovascular disease? When you go to that provider as an educated consumer, that puts them on the spot to address your questions. Now, the final part of that I want to make is that this distrust that has accumulated over history is well based on facts in the past. But that's why it's so important that we work on diversification of the workforce so that we have like minds and like individuals who can understand and relate about our concerns for the previous history of experimentations and the concern about side effects of medications so that we can meet that individual and kind of help allay those fears. One of the things that the Association of Black Cardiologists has worked very diligently on is diversification of workforce, increasing the number of African Americans in the healthcare profession. And also being sure that when we look at research, that there are researchers who look like us who will have concerns and questions like we have, that we're going to be sure that the database is made up of people who are of African American descent, Hispanic descent, women, so that the results of those clinical trials are truly reflective of the patient population that we serve. And so those are just some of the things that I think that we need to work with in terms of enabling people to have more trust in the system, enabling people to be more apt to present and to share the concerns and the symptoms that they have. Final point, it's written in the data that people are more likely to confide the true history if they can relate with their provider. They're more likely to be compliant with their medications if they know that the provider is going to listen to their questions and their concerns. So I think that's all part of the important part of why these conversations today are extremely important and why we have to work forward to diversification of that workforce.
Dr. Fletcher is so correct. And as he knows, we all are working for equity providers and having patients see those that they can trust. They can certainly feel good about their relationship with them and moving forward with what they need to do to protect themselves. I will also say, Dr. Fletcher mentioned earlier that education is the key. Although we are doing a lot to bring about the equity, we still see that minority physicians, minority nurses, minority caretakers in a hospital or a clinic setting are still in the minority. And how do you deal with those issues and get yourself prepared to be able to interact with what is before you? We see it in rural America. We see it throughout this nation. We're 13% of the population, about 8 or so are much, much less percentile of the physician provider. And even for heart transplants, I received a heart transplant within 2 weeks of dying.
Wow.
But yet average transplant is 8 years. So clearly, to Dr. Fletcher's fantastic points, it is important to make sure that you're interactive, that we put in place what we can, but it's kind of a long-term gain. And the short term, as he also mentioned, is going to be that education and beginning to make sure that communities are comfortable with what's before them and knowing how to ask questions and respond and keep digging to make sure they have the knowledge they need to be successful. And I think that's part of what I'm attempting to do with my nonprofit that I've started.
You know, if I may add a point there, when we talk about transplantation, for example, the diversification of the transplant team is extremely important. These decisions as to who gets a transplant and who doesn't, who
Yes.
is going to get an LVAD, left ventricular assist device, and who doesn't, those can be very subjective decisions sometimes. We hear things like compliance, we hear things like family support, we hear things like, education, we hear things like insurance. You have to have individuals at these tables making these decisions who are going to advocate for
Yes.
patients.
Yes.
They're not just Black patients, white patients, it's older patients, it's female patients. It's extremely, I mean, I'm involved in a lot of boards and a lot of committees.
Yeah.
It's extremely important that you have people who have a broad perspective of the whole subject matter participating in these decisions. When Dr. Nichols was being considered for that transplant, people were saying yes or no as to whether or not she got that transplant. Ultimately, they said yes or no as to whether or not she would live. And so it's extremely important that we are part of that overall scheme of decision making about all aspects of healthcare, not just transplant, but all aspects.
And let me connect that dot for you, Pam, because at first I was on the list for an LVAC and was in the process of receiving an LVAC. I had an incident in which I had a blood clot, which put me back in the circle of being looked at again. But I believe that I was probably in that situation of where I work, who I was, I became privileged. Why? Because once I got on the phone and I called a very important individual in this nation who had been a transplant surgeon who I knew very well. And I believe there had been some calls and some interactions around who I am, in addition to doing the proper assessments. I am now on the Johns Hopkins Heart and Vascular Board. I see no challenges in how they make their decisions. But to Dr. Fletcher's point, it boils down to what people see or feel in reference to the person that's before them. So clearly, if you ask me how did I get a heart transplant so rapidly, my first comment is going to be God. My second comment is going to be the privilege, the opportunities, the relationships that I have, but everyone doesn't have that. And to Dr. Fletcher's excellent point, that's another reason to be in the room. That's another reason to be on these boards so that those individuals who see you can also be in a room to advocate for your life.
You know what? I'm going to put a quarter in the meter and we're going to park here for a second because you guys have said some things that is not applicable to most Black, Mexican, communities. You talk about privilege. You guys have 15 titles behind your name. You're known all over the world. And you talk about advocating. But with advocating, if you're this woman that's sitting in, or this man or this kid sitting in Alabama or Arkansas, and you don't have anybody advocating for you. You don't even know, you feel bad, something is happening, but how do they get someone to advocate? Even with you, when we go into a hospital, I don't see a lot of people that look like me. Medical community. Then when you go to specialties like a cardiologist, you don't see that. You probably see it if you go to, ABC conference, but other than that, so how do they get people to advocate? How do they find those people? The normal people, not the privileged people.
Great question. Dr. Fletcher?
Absolutely. This is an opportunity for me to put on one of my hats. I'm president of the Association of Black Cardiologists, and we talked about, cardiologists. We're 12, 13% of the population, and the number of Black cardiologists in this country probably is south of 4%. But one of the important aspects of the Association of Black Cardiologists is that we advocate for our patients. We have a current campaign going on right now called Cardiovascular Deserts Initiative. And that initiative was put together by the Vision of ABC members looking at where the highest amounts of cardiovascular morbidity and mortality are in this country. Okay. And that happens to be in the South, Mid-South, Southeastern portions of the United States. No matter who lives there, those areas are areas where you have lack of cardiovascular care. There's an absolute desert where there are no cardiologists whatsoever. There's also a relative area where the ratio of patients to cardiologists is very, very, very high. And so we're looking at an initiative as to how we can make a difference in these areas, no matter who lives there. Black, white, Hispanic, Asian, Indian, it does not matter. We want to be sure that all of those individuals in those areas have access to cardiovascular care. It's a two-pronged approach. Education, as we mentioned earlier, is very important. So we want to educate the community members. In this case, the initial aspect is about a risk factor called LDL-C cholesterol, which is the bad cholesterol. So we want to educate the community members about the importance of getting that checked, the importance of that it plays as a risk factor, and then when appropriate, the importance of getting it managed to goal. The second component is educating providers. It doesn't necessarily have to be specialists, primary providers, hospitalists, primary care physicians, nurse practitioners, physician assistants about the importance of LDL as a risk factor, screening for it, and when appropriate, treating it to goal. And then establishing support networks where they can get consultation from specialists if they need those inputs, and then also to refer those patients when appropriate. Now, the importance of that program, LDL-C, the cholesterol is just the first component. You can intersect hypertension, intersect obesity, diabetes, maternal health. All those things are intersectable in this desert campaign. But the whole reason of this is to shrink the deficit of cardiovascular care in these areas. These are the highest areas of morbidity and mortality in the United States. And so this is an attempt by the Association of Black Cardiologists and many of its partners. We have many, many partners who are collaborating with us. ACC, the American College of Cardiology, American Heart Association, and many, many other organizations and industry partners. But the key is to embrace the problem. The problem is that you have individuals who do not have access. To embrace the problem, you have individuals who have lack of individuals who they can go to see to address the problems, to embrace the problem, to elevate the knowledge level of the providers who see these individuals, that you have high-risk individuals in these areas who need to be treated based on evidence-based guidelines and goals to meet those challenges across the board. We could talk about peripheral vascular disease, stroke, heart attack, congestive heart failure, all of these are covered. Now, the final point I'll make with that, unfortunately, this area of the cardiovascular desert happens to be the area where the highest percentage of African Americans live. And so the deeper you get into the desert, the more the percentage of African Americans happen to be. So that's kind of taking, the water to where the fire is, if I could use that rough analogy. We want to kind of go where it's burning at its highest point. And then hopefully, as a result of this pilot project, we're going to get more enthusiasm, more resources, and more focus on the nature of this beast.
Wow. Preach, Dr. Fletcher. That's outstanding. Dr. Nichols.
Man, it's what's so essential for me after my career in community, in education, in public health, in corporate America. It became very important to me that one of the open areas for me as a physician was, what did I know about my death? What did I know about my health care? What did I want to know about those things? And how did I want to personally approach it? And so it became very clear to me that I was left here to do some nonprofit work. And I was fortunate enough, and became very clear through God, through the work that I was doing at the time. I was under the care of transplant surgeons and others. And I came out of the hospital and I started a nonprofit called the Samaritan Health Project. We all know the story of the Samaritans, of the Samaritan who laid by the road and everybody walked by them. I could have gone into many areas. I'm a family practice physician by training. I did emergency room, did all of this, I said, population, public health, multiple things. But it was clear to me that it was my job to take on the community, to touch bases, to connect with those things that Dr. Fletcher just talked about. How do you not only prepare and get in place the actual workforce, the operations, the individuals, the understanding, but how do you prepare the people in the community? So my Samaritan Health Project does a lot of work. Right now we're working in Little Rock, Arkansas, which is my hometown, had to go home. And we do things to engage, community engagement, in order to help those individuals become more advocates for themselves, to better understand what their roles are. How do they have a conversation with their doctor? Not only looking at the health equity piece of it, how do we make sure they have their essential healthcare needs met? Very excited by the opportunity. We're right at the beginning of a lot of this work, but we're well on our way.
Thank you.
You're listening to KMOB1003 Global Media. More from this conversation in the next segment.